Hi, my name's Marian, and I'm presenting with Alyssa Locke and Genesis Loya. Our case study focuses on Ricardo Mendoza.
This is our table of contents of the overview of our presentation. We are first going to discuss our patient overview and the case information as it was presented to us, as well as our three care plans that each have a nursing diagnosis regarding this patient, and our conclusion that states how we will implement this into his care.
For our patient overview, Ricardo is a 60-year-old Hispanic male who was admitted with squamous cell carcinoma of the right lung and underwent a right lung lobectomy. He's full code and has no known allergies, and his wife Adelaida is present and involved in his care. During our assessment, Ricardo had a right-sided chest tube um, at 20 negative centimeters water seal, and he reported pain at 8 out of 10 and stated, I can't breathe and I can't take it. It's hard to breathe and I can't take a deep breath. His oxygen saturation had dropped to 88% on room air, and his respirations were 30 and shallow. His heart rate was 122, and he also had absent right upper breath sounds and crackles in both lower lobes. These showed that his respiratory status was worsening and needed to be addressed first. Based on these findings, our first priority nursing diagnosis was impaired gas exchange related to ventilation perfusion imbalance, as evidenced by oxygen saturation of 88% on room air and shallow respirations of 30 per minute. Um, our goal was by 9 p.m., Ricardo would maintain an oxygen saturation above 92 on prescribed medication. For our assessment, the subjective data was Ricardo stated that I can't take a deep breath and it hurts to breathe. His objective data was 88% on room air, respiration was 30 per minute, and crackles in bilaterally lower lobes. Um, our priority interventions was to administer oxygen by nasal cannula as ordered and reassess his oxygen saturation. Our second intervention was to elevate the head of his bed between 30 to 45 degrees to promote lung expansion and to help him breathe better. And our third intervention was to continuously monitor his oxygen saturation and assessing his respiratory rate. Um, for our evaluation, our EHR did not provide a post-intervention data, so we couldn't determine whether the goal was met. But we did say that if his oxygen saturation improved above 92%, we would keep the current plan. But had it remained below a 92% or continued to worsen, we would notify the provider and administer um, a higher dose of oxygen if that's what was ordered.
Our second care plan was ineffective airway clearance with a nursing diagnosis of ineffective airway clearance related to pain with breathing and coughing, as evidenced by bilateral coarse crackles and an inability to take a deep breath. Our subjective assessment data that led us to this conclusion was statements from Ricardo that included, I can't take a deep breath and it's hard to breathe, as well as a statement from his wife where she asked, why is it so hard for him to breathe? Our objective assessment data included the bilateral coarse crackles heard when auscultating the lungs, and right upper lung sounds were absent when auscultating, as well as a chest x-ray that showed right pleural fluid and an oxygen saturation of 88% on room air and respiratory rate of 30. Our goal was within 12 hours, Ricardo would demonstrate effective coughing and clear breath sounds when being auscultated. And our nursing interventions to hopefully get to that goal were to monitor his respiratory patterns, such as the rate, depth, and effort, and assess any changes. And our rationale for that was that a normal respiratory rate for an adult without dyspnea can vary between 8 and 20, and the presence of secretions can increase the rate and effort, as shown in his O2 stats and the respiratory rate. Our second intervention was to position him in a position that allows gravity to assist with the movement of secretions. Our rationale for that was that positions like high fallers can decrease the risk of aspiration of secretions and allow gravity to help move secretions. Our third nursing intervention for this diagnosis was to help the client perform diaphragmatic breathing and controlled coughing. Our rationale for this was that airway clearance techniques were found to improve lung compliance and expansion and mobilize secretions. There's currently no post-intervention data that we were provided with for this patient, so his provider ordered the use of an incentive spirometer for every hour while awake, and education on this device would help him to achieve this goal. With the order of the incentive spirometer and the rest of the current care plan we have for this, I would not make any revisions since there's no data regarding his response of the current plan of care. And as mentioned, the interventions and rationales would hopefully help with the airway clearance.
Then our third care plan was due to acute pain related to presence of chest tube, as evidenced by the patient reporting pain of 8 out of 10. The patient also states, how long will I need this tube in my chest? And his wife states, my husband is in pain. Can you please do something? As well as they both claim to see reddish fluid coming out of the chest tube. We also know that he is set to 20 centimeters water sealed draining with reddish fluid, and his skin is intact except for the chest tube site. The goal would be within 12 hours, the patient will report of pain of 3 out of 10 or lower, achieving the comfort function goal without any side effects. In order to achieve this goal, we want to perform a comprehensive assessment of pain, including the location, characteristics, duration, frequency, quality, and severity of pain. By doing so, we can build an individualized care plan just for him. We also want to request orders with provider to implement pain management interventions to achieve a satisfactory level of comfort. So we want to advocate for our patient if he is experiencing any more pain. And we also want to use a self-report pain tool and asking the patient to identify a comfort function goal that will allow the client to perform activities. So by working with the patient, we can see a pain that he wants to achieve and we can work our way there. We also want to administer pain medication that is ordered by the provider using the 8 rights to avoid any errors. And we want Ricardo to report a pain of 3 out of 10 or lower after receiving pain medication from the PCA pump within 12 hours if the patient still reports bad pain within that time frame. We will perform an assessment on the surgical incision area and the chest tube site and notify the provider immediately. At this time, it is important to educate Ricardo and his wife on what the PCA pump is and how to use it, when to use it, and what side effects could happen and should be reported. To conclude, we noticed that Ricardo's first priority was oxygenation due to his dropped oxygen levels. We also want to control his pain in order for him to increase his breathing. And also we want to focus on education on the insensitive spirometer, signs and symptoms that he should report, the surgical incision care, medications, family, including family into his care plan, and also help with his health promotion and quitting smoking. These are our references.
Thank you.
Thank you.